that she will pass to the nurse or whoever is assisting to be able to maintain sterility throughout the procedure. I want you to ask yourself, why do we want to maintain sterility? We're going into a faux patient's abdomen who has some ascites, who requires a drain in situ. We have our patient here. We have our aseptic setup technique with claw hex. Okay, so whenever you're ready. So we have used the ultrasound machine prior and we have found the ascites. And the patient has obviously signed consent. We have coags and we have platelets and we have a path form because we're still going to send this away. So we've cleaned the area. We now need to draw up some local. Sister, will you put some gloves on, please?
Never use gloves.
Okay. What have we got there?
So lignocaine, 2%.
Yeah, expires
March 18.
March 18. So you would never give something you didn't know what it was. Always good for a doctor to check. Always good, obviously nurses check. So we've now changed from the drawing up needle to the local needle, where she's going to do a skin bleb and then start localizing. Drape first. Very good idea. But we have drawn up the local. So we're using a fenestrated drape here that is not disposable. So we're literally just going to have the area acquired. So you can just bring that in a bit where we haven't claw hexed. So just, yeah, tuck it in. So you've only got your claw hex. That's great. So that's our skin prepped area. Okay, now we'll go with the local skin bleb, straight in at 90 degrees. Now, it's a matter of pushing down and drawing back, pushing down and drawing back, pushing down and drawing back, and then we know from the ultrasound that it's a few centimeters from the skin where we start coming into the ascites. We're not hitting ascites there, so that's fine. We've localized that area down. So now we're going to, yeah, we're now going to use the blade. But before we use the blade, we might just prep our drain with saline. This gives the local anesthetic time to work. So with another syringe, we have another syringe. Our nurse is onto that. We are now going to prep everything with a saline flush. We're also going to wet one gauze and run it down the outside of the drain itself. Yep, so everything's going to be flushed. This ensures that it's patent and it actually allows for it to slide through the skin easier. You can talk, it's fine. There are two entry needles you can use. One would be a thin wall, depending on the length you need. Otherwise, we use a Gelco. So everything is now prepped and ready, so that's also given time for the anesthetic to take effect. So we're now going to go back to, yep, so normally it's just a straight in and out. Yeah, beautiful. And the Seldinger requires that you use dilators. So we have dilators here too. So we're going into our entry site, yep. And probably best to have a syringe attached to the end of that. It's alright, she can use that one. So as you go in, you are also creating some negative pressure and pulling back until you hit the ascites. You will definitely feel, have you pulled back any at all during that? Okay. So we have struck ascites, so we're now going to leave the sharp in situ, remove the syringe, and we're now going to put in our wire, which will maintain our access. We're going to maintain sterility and keep it on the green field. The light's not quite right, Jen. Yeah, I think that's better. Okay, so once we've maintained our wire in there, we can then remove the sharp, controlling the wire. This is where you sometimes need another pair of hands. That's it. And now we're going to remove, they can't see outside our field. That's fine, I can edit this. So very good, we're now removing the sharp, and we're now going to dialyze up our hole, because as you can see, it's not too big, and the side strain we're putting in is going to be an 8 French pigtail. This bit's quite tricky, trying to get the wire over the top of the dilator. It's good to make a note of the wire coming out the other end before that dilator goes anywhere near the actual insertion. So controlling both wire and dilator, so it goes in a few centimeters and in and out and in and out. Sometimes you might need to twist a dilator in, but that looks good. And now we'll go for the next size up. So we've started with a 6 French, and we're now going to dialyze up to an 8 French. They are very tricky to control because they do tend to have a mind of their own. So we've got the wire out the other end. Once again, we keep an eye on that, and we're just going in a few centimeters. Put your hand closer to the actual, because in skin it's a bit tougher. That's really good. And then we are now ready to have the drain in situ. Again, controlling that wire.
Have you taken the sharp trocar out?
Yes. There's nothing in there. Oh, yeah, it didn't come with that, so that's fine. This drain has its sharp trocar out, and we are ready to just spreading that over. Ideally, it doesn't go anywhere near the skin until we've got wire out the other end, and we're going to control that wire going in directly 90 degrees. And this is where you may have to twist a little. Okay, as you are going in, more control. So can you just use your hands, Jen, to point? So we need to push and pull at the same time. One hand up, higher. Yeah, that's it. And we're going, so you can't bend it anymore because that's perfect. Okay, so get ready to put a finger on it. Where's your wire?
Always.
Hang on to your wire.
Yep. Pull them out at the same time.
Yep. Okay, we have our wire coming out. Perfect. Put a thumb over that so we don't lose any. You then have a stop here, right here. Some people like to use a tap. So putting on, yep. And then at this time we're trying not to lose too much fluid. We can then stop the flow. But firstly we need to secure the pigtail. So we're going to pull that tight and wrap it around wrap it around a few times and then pull it up. That's good. Yeah, wrap, and then pull your plastic sleeve over it. That's great. So now we have the pigtail secured. We can take a specimen. It's not going to leak everywhere. Let's make sure it's flowing as well. And we should be getting some ascites in there. Excellent. So that will be sent off for pathology. And now we're going to apply the dressing. So you've got one dressing over there. Yep. So some places require an antimicrobial patch. I think it goes sunny side up, blue side up. and then we apply a specific dressing for holding down drains. You might just have to lose a little bit of your drape there so you can undrape. Yeah, so you can, of course. We might just get a bag if we can, Jen. So, okay. So, no, start at the top here. Jen, come over here because I can't explain. Yep. Yep, that's fine. No. No,
See
it's
that
not.
one at the top? Yeah.
That's all right. Can we get a new one?
Yeah. Johnny. Here, I'll show you on this one. So stop videoing. Sorry.
No,
That's
I
all right.
can't. We need to keep going. Just get
Okay.
it.
So when you do this, you want to take these off
Yeah,
first.
okay.
Then
Every dressing is going to have its own idiosyncrasies.
tube goes in there. Take that off. Wrap the tube down. I usually put it on now, and then I take that out from underneath, and then that goes across like that.
So we're just going to get a new one. It's all about learning. And making sure our patient is happy and not in any pain. Generally they would have IV access. We would have some sort of observations on them.
Thank you.
And that was very close to your sterile fill there, sister.
Not to mention.
Yep, so we want to face the drain so it's going to go downhill. So when the patient